Welcome to AZIN's Guideline Updates. Episode G4, Community-Acquired Pneumonia. I am Dr. Z, and with me is KC educational only, not individual medical advice.
Dr. Z, I looked this up before we recorded, and I found two guidelines. The 2019 ATS/IDSA guideline, and then a 2025 ATS update. Which one am I supposed to be following?
Both, and I will explain why that is actually not confusing once you understand the structure. The 2019 ATS/IDSA guideline is the current joint standard. It is still operative. The 2025 ATS update is an interim, 4-question update published in AJRCCM that answers specific clinical questions the 2019 guideline did not fully address. It is not a replacement. You use them together.
For questions, what were they?
Lung ultrasound versus chest X-ray for diagnosis. Whether to give antibiotics in severe CAP when a respiratory virus tests positive, antibiotic duration for outpatient CAP, and corticosteroids. That last one is the biggest practical change from the 2025 update.
Okay, but before we get there, can we talk about CAP? Because I was trained that if a patient comes from a nursing home, that means MRSA and Pseudomonas coverage.
That is the 2019 guideline's biggest structural change, and it is still being ignored in a lot of hospitals. CAP as a category does not exist anymore. It was eliminated. Nursing home residents alone does not justify broad-spectrum coverage. The question is specific validated risk factors.
What are those risk factors?
Prior respiratory culture, growing MRSA or Pseudomonas, or hospitalization plus intravenous antibiotics within the previous 90 days. That is it. Dialysis status, nursing home, chronic wounds, none of those alone trigger broad coverage. They have to have that combination of healthcare contact and prior exposure.
So if I get a 74-year-old from skilled nursing with pneumonia and no prior MRSA cultures and no hospitalizations in the last 90 days, standard CAP coverage?
Standard CAP coverage. Beta-lactam plus macrolide or doxycycline, or a respiratory fluoroquinolone. Not vancomycin and piperacillin-tazobactam. And if you're unsure, order an MRSA nasal PCR. A negative nasal PCR has a negative predictive value over 95% for MRSA pneumonia.
That is useful. Now, steroids. I feel like this has been going back and forth for years.
The 2025 ATS update resolves it. 2 clear positions. First, for non-severe CAP, do not give corticosteroids. That is now a strong recommendation against. Second, for severe CAP without influenza co-infection, corticosteroids are conditionally recommended. The preferred agent based on the CAPE-COD trial data is hydrocortisone.
What counts as severe CAP?
The ATS/IDSA 2019 minor criteria framework. You need either one major criterion, which is mechanical ventilation or septic shock, or at least 3 of the minor criteria. Respiratory rate over 30, PaO2 to FiO2 ratio under 250, multilobar infiltrates, confusion or altered mental status, BUN over 20, leukopenia below 4,000, not from chemotherapy, thrombocytopenia below 100,000, hypothermia, or hypotension requiring aggressive fluid resuscitation.
So a patient going to the ICU with severe pneumonia and no flu should get hydrocortisone?
Conditionally, yes. And the 2024 SCCM focused update on corticosteroids aligns with this, giving it a strong recommendation for hospitalized severe CAP. So now ATS 2025 and SCCM 2024 are saying the same thing. The flu exception is a hard stop. Do not give steroids in influenza-associated severe CAP.
What about antibiotic duration? I was always taught 7 to 10 days.
The 2025 update changes that. For non-severe inpatients, 5 days when the patient meets clinical stability criteria. For outpatients, you can go as short as 3 to 4 days if they are clinically stable. For severe inpatient CAP, at least 5 days as a minimum. That is a strong recommendation for the severe inpatient group.
Clinical stability criteria. What are those?
Resolution of vital sign abnormalities, improving clinical symptoms, ability to take oral medications. Basically, if the patient is on the floor, tolerating oral intake, not requiring supplemental oxygen beyond their baseline, you can start the clock for stopping antibiotics at day 5.
What about the macrolide situation? I have seen a lot of azithromycin ordered for CAP.
The 2019 guideline downgraded macrolide monotherapy. It is no longer first line for hospitalized patients because macrolide resistance in Streptococcus pneumoniae exceeds 30% in the U.S. Azithromycin monotherapy for a hospitalized CAP patient is not guideline supported. You use a beta-lactam plus macrolide together, or doxycycline is now an acceptable alternative to macrolide as the partner drug. That matters for patients with prior C, diff, or other macrolide contraindications.
And cultures. When do I actually need blood cultures in CAP?
Severe CAP, or patients with MRSA or Pseudomonas risk factors, or patients who received intravenous antibiotics in the prior 90 days. Non-severe CAP without those risk factors does not require blood cultures. This is another stewardship principle from 2019 that is still underapplied.
Give me the 3 take-homes.
1. CAP is gone. Use specific risk factors, not nursing home, as a trigger for broad coverage. 2. Steroids for severe CAP without influenza. Hydrocortisone preferred. No steroids in non-severe. 3. Target 5 days of antibiotics for most hospitalized CAP, and consider the MRSA nasal PCR as your de-escalation tool.
One question I still have. You mentioned the 2025 ATS update is not co-signed by IDSA. Does that matter?
It matters for how you frame it. You say the ATS 2025 update recommends, not the IDSA/ATS guidelines say. IDSA members participated in the panel, but the organization has not formally endorsed the update as of May 2026. In practice, the clinical recommendations are sound, but be precise when you cite it.
Got it. ASENS, episode G4, done.
Next up is G5, COPD exacerbations, and the GOLD 2025 framework. A lot of the stewardship themes carry over. See you there.